estimated 2 million Americans experience traumatic brain injuries each year. Such injuries occur every 15 seconds. While thousands die each year from their injuries, millions more are part of a silent epidemic. These injuries are internal and usually don't show on the outside. Brain injury has deep, tragic, and profound implications for the injured and their families and friends. It's common for survivors of brain injury to lose their jobs, homes, become bankrupt, and fall out of relationships with loved ones. A brain injury can happen to you or me at any time. Please listen carefully to the information in this program in case this sort of tragedy strikes you or a member of your family. Today's speaker, Dr. Barbara Welsh-Osga, has heard newly injured brain injury survivors say they feel fuzzy-headed, as if they're in a fog. Sometimes they think they see things clearly, but the mist skews perceptions. They're like city smog-dwellers who forget clear skies. During this fascinating interview, we will explore ways to help survivors develop the compass required to take the painful and joyful journey out of the mist. It is a pleasure to welcome our speaker for this Brain Injury Speakers Series. Dr. Barbara Welsh-Osga is a clinical psychologist in private practice with 20 years experience working with traumatic brain injury survivors as a neuro-rehabilitation specialist. She graduated with MA and Ph.D. degrees from the University of South Dakota. She is a lecturer and educator on issues relating to brain injury and a consultant to school districts regarding how to reintegrate students, brain-injured students, back into the school setting. So please join me in welcoming Dr. Welsh-Osga. Since brain injury is not a mental illness, what is the role of a psychologist in the recovery process?
For brain-injured survivors, we would concentrate on the cognitive, behavioral, and emotional sequelae that might be the aftermath of their injuries. And maybe we'll be talking some more specifically about each of those areas as we go along today. That and one of my jobs I often see is to assist the families and the caregivers to know their brain-injured loved one in a new way, to know them and love them in a new way, and be able to integrate them, reintegrate them back into the family life and their day-to-day life with knowledge of their new selfhood.
From a psychologist's point of view, would you sort of paint a picture of the recovery journey?
Upon awakening from a coma, if a person experiences a coma, there's a lot of confusion, a lot of fear, but it's certainly not difficult for our survivors here today to imagine what it feels like to wake up and really not know what you used to know, not know why you're there and have no memory of your injury perhaps, a lot of confusion about why limbs aren't working the way they used to, a lot of confusion and fear about why your speech isn't working like it was before. When your body isn't the body that you remembered it last to be, or when your mind isn't the mind you remembered it last to be, it's very frightening. Moving on to the rehab stage, lots of frustration with the lengthy, detailed, cumbersome rehabilitation that some people have had to go through, learning to walk and talk again, learning basic skills again, lots of frustration and maybe some anger about your injury in the first place. A lot of people got injured through no fault of their own. There can be some anger during that stage about why me? Why am I having to go through this? And eventually, I've seen a lot of my clients go on to be bigger people than they were before their injuries. They have incorporated now their entire rehabilitation experience into who they are, and they actually emerge, as you might expect, a butterfly emerging from that rehab cocoon, bigger people with different capacity and an overriding sense of survivorship that wasn't even a part of their vocabulary before their accident.
A sharp memory, the capacity to organize one's life, those are traits that are valued in the business world, and in our economy, those are rewarded. Brain injury, I think, tends to get in the way of those traits. Is that a particularly frustrating situation then for survivors?
If you have a brain injury, it's difficult to think back, okay, so I came into this room after I went upstairs, and I know I was folding clothes upstairs, and I had the pencil in my hand because I know I dropped it on the bed and thought it, we can think through that.
Sure.
For a brain injured person, it's very difficult to retrace their steps because of the distractibility and the inattentiveness, which means that they can be inattentive to the moment, so that whatever they were doing upstairs 5 minutes ago is pretty much not available to them to recount and retrace. So the frustration mounts for them. You can imagine what it's like if you're living that kind of existence in your own home, just to do your what we call ADLs, activities of daily living. You can imagine what it would be like to think about taking on competitive employment or returning to your old competitive employment, where speed and accuracy are oftentimes the expectancies of the day. And you've got the exigencies of the moment in the work world, where people are knocking on your door, interrupting you. You're supposed to be multitasking. Remember what you were doing, and now entertain the question that this person has for you as they interrupt you. Get back to what you're doing. Know where you left off. Not have to start from scratch again. So you can imagine how these very fundamental skills that they struggle with just to get their day-to-day lives in order are just totally elusive.
The issue of self-starting or initiation, is that part of the problem as well?
Yes. It's a symptom called adynamia. And the frontal lobe, among other things, among many other very clever, high-level functional skills housed in one's frontal lobes right up here in the forehead region, is that ability to generate thoughts. If you're going to have a birthday party, you can generate a number of different ideas for your 3-year-old's birthday party. Off the top of your head, you can think of just a bunch of ways you could pull off a really great birthday party. If you ask a 3-year-old, what would you like to do for your birthday, they're likely to have difficulty generating those ideas for you. Well, some 3-year-olds might not, but for the most part, because their frontal lobe skills in terms of generating solutions to problems hasn't evolved well enough yet. And to a great extent, after a brain injury that's involved the frontal lobes, the same problem can arise. It can strip the frontal lobes of its capacity to generate ideas. So it just simply does not occur to one to engage in a conversation. It might simply not occur to a person to check to see if they've got their wallet before they leave the house with their money for the bus. It just simply doesn't occur to them. The idea doesn't come up. They can be sitting, and people will oftentimes mistake this adynamia as laziness or lack of motivation, or he's depressed, uncooperative, doesn't want to go to therapy. Well, for them, it may not have occurred to them that it was therapy day. It just doesn't occur to them. One of the most profound cases of adynamia that I ever dealt with, I won't tell you all of the symptoms because we are being taped here today, but one of the symptoms that I can relate to you was sitting down at the table to eat, and this man's family would say, "Well, Dad, so are you hungry?" "Yeah, I'm hungry." "So, Mom fixed your best favorite meal here tonight. What do you think?" "Oh, yeah, all right." And everybody would start eating, and he would just sit there. And they would ask him, what's the matter, Dad? You don't like what we're having?" "Oh, no, I love it." "Okay, well, so let's eat." "Yeah, let's eat." And he would continue to just sit there. It never occurred to him to pick up his fork. It just never occurred to him. If you placed the fork in his hand, it would trigger an automatic behavior and he would begin to eat. But if you didn't cue him to pick up that fork, then the rest of the behaviors didn't fall into place. So you could go to your GP or some other doctor on your list and say, "Gee, I just don't know what's wrong with Dad. I think he's depressed about this brain injury thing and everything." And all of a sudden people are diagnosing depression or he's lazy or unmotivated, or he just wants to milk the sick roll, so he wants us to feed him, when actually that's not it at all. So problem solving through those kinds of adynamia issues is important, because I think it saves the reputation and the self-respect of the survivor who really is suffering from a symptom that needs cueing rather than labeling and ridicule.
The opposite of humor is depression, and it's been said that all brain injury survivors suffer depression. What are some of the very real losses that survivors experience that would cause depression?
I'm not so sure that I would go so far as to say that all brain injury survivors experience depression. I think there's a difference between grief and depression, clinical depression. And if we throw the term around, if we throw clinical depression around as a term and make those assumptions about people, I'm afraid that the Eli Lilly company will run out of little Prozac pills. Everybody will be throwing medication at people that may not need it. I think that there are grief responses that are so natural and so normal, and everybody would be experiencing them if they had to go through losses like these. Losses that you're referring to are of your role in society, your losses of independence. Many people need some kind of, whether it's supervision, coaching, assistance, loss of mobility, loss of a sense of value to the community through the old ways in which you used to feel valuable. Really, loss of self is the biggest, and loss of independence, loss of mobility. Many people lose their ability to drive. You can't imagine what this city is like to get around in. Everybody thinks, oh, well, we'll take the trolley, take the bus, what's the problem? I have people who, it takes 6 hours for them to get to my office, and I'm pretty centrally located. 6 hours and 3 bus changes. Now, if you've got any problems with your organizational skills, your frontal lobe executive skills, can you imagine how many opportunities there are while you're waiting on the bus for the next exchange to lose your wallet, lose your bus pass, forget your jacket, forget where you were going, get on the bus the wrong way? You can't imagine. So the loss of mobility, while others might think, well, you can take a taxi. Well, if you can't afford to take a taxi because you've lost your job, you've lost your financial security, your income, these are devastating losses.
You mentioned being careful with clinical terms. Brain injury is not a mental illness, but can a traumatic brain injury cause a mental illness?
If I understand what you're getting at, brain injuries can trigger and do often cause many mental health issues that would not otherwise have been there. Such things as clinical depression. You can get awfully depressed, and I say, grief-stricken to begin with, but eventually when you can't get rid of the grief, and it turns into clinical depression, you've got the depression, you've got anxiety. People are very anxious about what's going to become of them. Those symptoms, that you might call them, can be triggered by the injury. Obsessive compulsive disorders are sometimes triggered, where you get somebody who perseverates on things and they can't get off of it. A frontal lobe symptom where they just can't stop. In the real basic form, you could see somebody signing their name, and my name that ends in an A would just go on for a few more A's, or we might get stuck on an R and make a few R's before we get on to the A. That would be a basic form of perseveration, but you can get it in other forms where people just can't let go of ideas, and it's time to change a topic, and the person doesn't realize it's time to move on and can't move on, can't shut that thought off. Eating and sleeping problems that people might seek mental health counselor for, or a psychologist for anyway, those can come up frequently with disturbances in certain parts of the brain functioning. So yes, you can get mental health symptoms from, and certainly family dysfunction and those kinds of things.
Sure. Survivors sometimes describe the experience after a brain injury as being in a fog, and they're coming out of the fog. Is there a term for that, and how do you help someone as a psychologist come out of the fog?
One of the very devastating side effects of some brain injuries is a condition called anosognosia, a symptom called anosognosia. And it simply means the brain's inability to detect the brain's own errors. So the brain doesn't know what the brain doesn't know. And so if I were to call you Mr. Smith in our conversation, well, Mr. Smith, I would be able to self-monitor and hear what I've said and check that out and say, no, I believe it's Dr. Baker and not Mr. Smith. And I would catch myself and I would say, Mr. Smith, I mean Dr. Baker. If you have anosognosia, you don't recognize that you're making errors. And sometimes what's required, but this is some of the reasons why people need and benefit from coaching, coaching from loved ones and coaching or caregiving, however you want to put it, to help them to see where their errors are so that they can begin to build compensatory strategies to not make those errors in the future.
What are some of the compensatory strategies that you might teach someone over a period of months?
Sometimes I'll ask people if there's a behavior, for example, that they don't forget to do, they always remember to brush their teeth, that's something they always remember, then we tie a string to the end of the toothbrush onto the pill bottle so that when you pick up your toothbrush in the morning you cannot forget to take it, and when you brush your teeth at night you cannot forget at least those 2 doses. I have people who we've rehearsed, rehearsal. Structure and repetition and rehearsal are really important. I have people who have safety issues. They'll open their door to a stranger at 4 o'clock in the morning. They'll sign up for things of callers on the phone. People will rip them off financially with salesmen on the phone. So we have posters in big bright letters posted by their phone with dialogue that says, I do not buy or sell anything over the phone, thank you, goodbye. We'll have dialogues that they practice ahead of time. I have people who will practice on the bus, especially my women clients. I'm sorry, but I don't give my name or phone number to people on the bus. You know, thank you for your interest, but I'm not interested. And I have a policy. That's one of our catchphrases. I have a policy. I don't do such and such. And you know, you'd be surprised how dramatically somebody can compensate, how dramatically their errors drop if they just have 1 or 2 simple little compensatory strategies in place and well rehearsed.
Well, we have a number of survivors in the audience that I'd like to invite perhaps to ask some questions who may themselves have experienced some of the frustration that you've been describing.
How can we help each other and helping the couple who is not the survivor but the other person helping what's happening, how to go through, helping other people?
I believe that it's important to have a rehabilitation psychologist on the scene with families pretty quickly after an injury. And oftentimes I think other professionals are waiting for some kind of depression or anxiety to set in, some kind of mental health or mental illness symptom to set in. And I think it's important to have a coach, a relationship coach that can help give some information, some education to the family about what to expect, to the spouse. Expecting, knowing, being well educated about knowing what to expect can preserve the relationship in those moments where it would have otherwise been very difficult to stick with if the spouse is uneducated and mislabels some of the behavior. Then all of a sudden you have anger and reactions and defensiveness occurring, whereas if they're ready for it and they expect it because they know what's coming, they can deal more effectively with their loved one.
This, I guess, is about education, and I had 2, I'll call them opportunities rather than problems this week, and it sort of rose in my face, these demons I still have, because it was like return to my adolescence with self and body image. I was attracted to this woman, and man, I don't think I fit anybody's pictures, but I figured I might as well, try to communicate. And so I'm talking, and she goes, why do you have that notepad around your neck? Well, I have a memory problem. And then she wants to see what I've written on my hand, and I just knew I didn't want to show it. Couldn't even remember what was there. But I eventually had a moment of choice to show her, and what was on there was get food stamps, and it was like, well, this can't be going well. And so, you know, I was aware enough to just give her my card rather than ask her for her phone number. I figure you'd need some time to sort this out. And so that was one. And the other thing goes, I go to a job assessment, and the counselor said to me, well, Mr. Cummings, you know, even our most severely disturbed people get jobs. And you know, it was like, well, I've gone from a fiber optic internet connection in my brain to probably a 28K modem. So I had time to not react too quickly. But then I said, oh, maybe she just needs education, because I've so far failed the McDonald's training manual and the Walmart training manual. And there's like an assumption. I got this quote from the McLaren Graduate School of Management. Not working is perhaps the truest definition of what it means to be disabled. And there's like this teenage thing, if we didn't have to go to school and if we didn't have to work, then our lives would be great. And what do I do to gently, you know, both, you know, deal with, well, I don't want dating tips, but I mean, you know, that's a real human thing. And then educating professionals.
It's very frustrating, and people that you would assume would know better say the most awkward and uncanny things to my clients anyway. And that's, again, where if someone's on your team, on your rehab team, whether it's a professor that you might have at the Acquired Brain Injury Program here in town, or your rehab psychologist, or somebody can help educate these people. As far as the social faux pas that one is concerned about in terms of trying to connect and date and reconnect with the opposite sex, that's another problem with the frontal lobe issues that come along. Sometimes there's that impulsivity where you said something you really wish you hadn't have said when you just met this person. You sounded like you were doing a very good job of what I call self-monitoring, that you were doing actually self-monitoring as you were doing the output, which is difficult for many brain-injured people to do. They can't perform and speak and say what they want to do, say what they want to say, and do what they want to do at the same time that they're monitoring themselves. You were listening to yourself and also monitoring the other person's response. You've got to do all of those things to be smooth socially, and the frontal lobe takes care of all those things. If you don't have a sense of humor, you are in big trouble, because this is a long-standing adjustment. And for every new situation you might come up against, you know, eventually when he marries these women off the buses, you know, you then are only faced with more dilemmas of how do we solve the next issue, and the next issue where my brain injury will now present a new dynamic in my life.
What do you say to the topic of case management? And then further, if there's no case management, you know, in some rural area, what would you say to the family members that would like to do something with their survivors besides sit them in the back room in front of a TV set or give up hope on them?
There's a lot of things you can do in your own home without a fancy neuropsychologist or rehab psychologist or speech therapist. That speech therapists and rehab psychologists have already designed similar things in fancier ways. You can do them at home. There are a lot of simple techniques, even reading the newspaper, getting a little paragraph out of the newspaper and going over and over and over it with the survivor that day and picking out the main points and then talking about it all week long. So by weekend, when it comes time for the church ice cream social on Sunday afternoon, they have something interesting to say.
The business of hope and realism, as a professional, how do you walk that line between being encouraging and yet helping the person understand their assets in a realistic way.
I can recall once in inpatient rehab when the person was spinal cord injured and brain injured, and they felt very strongly that they were going to walk again. So strongly that when the insurance company, this was back in the 80s when insurance companies offered such things, was going to get them a van, a wheelchair accessible van, and the whole works, they were refusing it. And the wife was refusing it, the spinal cord injured, brain injured husband was refusing it. And my intervention with them was simply this: well, if indeed that's going to happen for you and that cure will come someday, in the meantime, in order to take advantage of your outpatient therapies and make it easy on your family and easier on your wife, why don't we have them do the van for the meanwhile until you get the miracle that you're waiting for? And that was like opening the shades on a sunny day for them. It was amazing how they came around to that, because I wasn't dashing their hopes. Everybody who'd come in there and pounded away at them, you can't be serious, this is ridiculous. That kind of dashing, I call it knocking the legs out from under their tables, is unnecessary. But to simply engage with them, well, if and when your miracle comes, you know, that we can't say what day that's going to be. In the meantime, let's try to do this because we know what today is, and today is a wheelchair. I don't know what tomorrow will bring. I'm glad you have hopes that tomorrow will bring something different for you.
Well, you've treated people with traumatic brain injuries for several years. Is there a particular case that makes it all worthwhile for you? One that you're very pleased with the outcome?
I look at some of my survivors who have gone on to be such role models and advocates and networkers for their peers and do so much good in the brain injured community. All of those people give me such hope, and they set me at a place of extreme admiration for them.
Thank you very much. Thanks for sharing your thoughts with us today.
You're welcome.
Thank you. Thank you for joining us today. If you would like more information, please click to our website at www.sdbif.org or call us at 619-294-6541.